Good morning, my dear friends. I am Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia. Today we will talk about syncope. So syncope is a sudden, brief loss of consciousness with loss of postural tone followed by spontaneous revival. The patient is motionless and limp and usually has cool extremities, a weak pulse, and shallow breathing. Sometimes brief involuntary muscle jerks occur, resemble a seizure. Near syncope is limpness and sense of impending faint without loss of consciousness. Is usually classified and discussed with syncope because the causes are the same. Seizures can in some cases. So seizures can cause sudden loss of consciousness, but are not considered syncope. So seizures can cause sudden loss of consciousness, but are not considered syncope. However, seizures must be considered in patients presenting for apparent syncope because history may be unclear or unavailable, and some seizures do not cause tonic-clonic convulsions. Furthermore, a brief, less than 5-second seizures sometimes occurs with true syncope. Diagnosis depends on a careful history, eyewitness accounts, or fortuitous examinations during the event. Most syncope results from insufficient cerebral blood flow. Some cases involve adequate flow, but with insufficient cerebral substrate, oxygen, glucose, or both. Insufficient cerebral blood flow. Most deficiencies in cerebral blood flow result from decreased cardiac output. Decreased cardiac output can be caused by cardiac disorders that obstruct outflow, cardiac disorders of systolic dysfunction, cardiac disorders of diastolic dysfunction, arrhythmias too fast or too slow, conditions that decrease venous return. Outflow obstruction can be exacerbated by exercise, vasodilatation, hypovolemia, particularly in aortic stenosis, and hypertrophic cardiomyopathy, which may precipitate syncope. Arrhythmias cause syncope when the heart rate is too fast to allow adequate ventricular filling, for example, more than 150 beats per minute, or too slow to provide adequate output, for example, less than 30-35 beats per minute. Venous return can be decreased by hemorrhage, increased intra-aortic pressure, increased vagal tone, which can also decrease heart rate, and loss of sympathetic tone, for example, drugs, carotid sinus pressure, autonomic dysfunction. Syncope involving these mechanisms, except for hemorrhage, is often termed vasovagal or neurocardiogenic, and is a common and benign. Orthostatic hypotension that we have discussed in our previous lectures, is a common benign cause of syncope, results from failure of normal mechanisms, for example, sinus tachycardia, vasoconstriction, or both, to compensate for the temporary decrease in venous return that occurs with standing. Cerebrovascular disorders, for example, strokes, transient ischemic rates, rarely cause syncope because most of them do not involve the centrocephalic structures that must be affected to cause loss of consciousness. However, basilar arterial ischemia due to transient ischemic attack or migraine may cause syncope. Rarely, patients with severe cervical arthritis or spondylosis develop vertebrovascular insufficiency with syncope when the head is moved in certain positions. The central nervous system required oxygen and glucose to function. Even with normal cerebral blood flow, a significant deficit of either will cause loss of consciousness. In practice, hypoglycemia is the primary cause because hypoxia rarely develops in a manner causing abrupt loss of consciousness other than flying or diving incidents. Loss of consciousness due to hypoglycemia is seldom as abrupt as in syncope or seizures because warning symptoms occur, except in patients taking beta blockers. However, the onset may be unclear to examiner unless the event was witnessed. Causes are usually classified by the mechanisms. The most common causes are vasovagal, neurocardiogenic, idiopathic. Many causes of syncope never have a firm diagnosis but lead not to apparent harm. A smaller number of cases have a serious cause, usually cardiac. Let's talk about some causes of syncope. Cardiac outflow or inflow obstruction as a cause of syncope. Valvular disease, for example, aortic stenosis, mitral stenosis, tetralogy of Fallot, prostatic valve dehiscence, or thrombosis. So suggestive findings of this problem is young or old patient, syncope often exertional, recovery prompt, heart murmur. So diagnostic approach, by the way, diagnostic approach in all causes is that we have to put our attention that ECG and pulse oximetry are done for all causes of syncope. Okay, so we talk about valvular, right? Valvular problems, valvular disease. Diagnostic approach is echocardiography. Now echocardiography is the primary. Another cause is hypertrophic cardiomyopathy. Restrictive cardiomyopathy is a cause. Suggestive findings is syncope often exertional, recovery prompt. Heart murmur in hypertrophic cardiomyopathy, forced heart sound is in restrictive cardiomyopathy. So diagnostic approach is echocardiography. Another cause is cardiac tumors or thrombi. Suggestive findings syncope may be positional. Syncope may be positional. Usually a murmur, possibly variable. Peripheric embolic phenomena, and diagnostic approach is echocardiography. Pulmonary embolism is a cause for amniotic fluid embolism or rarely air embolism. Suggestive finding is usually from large embolus accompanied by dyspnea, tachycardia, or tachypnea. Often risk factors for pulmonary embolism, there are several. So diagnostic approach is DDMER, computer angiography, computer tomography angiography, or nuclear scan. Cardiac arrhythmias. Bradyarrhythmias, for example, due to sinus node dysfunction, high-grade atrioventricular block, or drugs. So concerning drugs, what we do have? Okay, about drugs we will talk a little later. But anyway, drugs, suggestive findings, symptoms of syncope, developing within several minutes of assuming upright position, the drop in blood pressure with standing during examination. So diagnostic approach is a clinical evaluation, sometimes tilt table testing. Autonomic dysfunction. What about bradyarrhythmias we talk? So bradyarrhythmias and tachyarrhythmias. Okay, let's finish with cardiac arrhythmia. Tachyarrhythmias. So tachyarrhythmias, either supraventricular or ventricular. For example, due to ischemia, heart failure, myocardial disease. drugs, electrolyte abnormalities, arrhythmogenic risk ventricular dysplasia, long QT syndrome, and dysplasia. Arrhythmogenic right ventricular dysplasia, long QT syndrome, Brugada syndrome, and preexcitation. Suggestive findings of these arrhythmias is syncope occurs without warning, recovery immediate or on awakening, may occur in any position. Patient taking drugs, especially antiarrhythmics or other cardiac drugs. And another suggestive findings is, if, for example, in Brugada syndrome, suggests structural heart disease. Diagnostic approach: if electrocardiogram is unclear, consider Holter monitor or event recorder, electrophysiological testing, if abnormalities detected or high suspicion. Electrophysiologic testing if abnormality is detected or high suspicion of them. Serum electrolytes if clinical reason for abnormality, for example, diuretic use, long diuretic use, vomiting, diarrhea. Ventricular dysfunction due to acute myocardial infarction, myocarditis, systolic or diastolic dysfunction, cardiomyopathy. Suggestive findings is a syncope, a rare presenting symptom of myocardial infarction. Most such patients are older concerning syncope. So syncope, a rare presenting symptom of myocardial infarction with arrhythmia or shock. Diagnostic approach: serum troponin, electrocardiogram, echocardiography, sometimes cardiac MRI. Another problem, for example, pericardial tamponade or constriction. Suggestive findings: jugular venous elevation, pulsus paradoxus more than 10. Echocardiography, sometimes computer tomography. Vasovagal neurocardiogenic cause: increased intrathoracic pressure, for example, tension, pneumothorax, cough, straining to urinate or defecate. Valsalva maneuver is a cause. Suggestive findings: warning symptoms, for example, dizziness, nausea, vomiting, recovery usually prompt but not immediate, 5 to 15 minutes or longer, but sometimes up to hours. Precipitant usually apparent. Diagnostic approach is a clinical evaluation. Carotid sinus pressure, warning symptoms, for example, dizziness, nausea, sweating, recovery prompt but not immediate, 5 to 15 minutes, but sometimes up to hours. Carotid sinus pressure. Precipitant usually apparent. Clinical evaluation. Another cause: swallowing, rare, warning symptoms, for example, dizziness, nausea, sweating, recovery prompt but not immediate, 5 to 15 minutes, but sometimes up to hours. Precipitant usually apparent. So diagnostic approach, clinical evaluation. So once again, okay, drugs. If we talk about drugs, orthostatic hypotension, of course. Suggestive findings: symptoms developing within several minutes of assuming upright position, drop in blood pressure with standing during examination. And diagnostic approach is a clinical evaluation, sometimes tilt testing. Orthostatic hypotension, autonomic dysfunction as a cause of syncope. Suggestive findings: symptoms developing within several minutes of assuming upright position, drop in blood pressure with standing during examination. And the diagnostic approach is a clinical evaluation, and why not tilt testing. Another cause of orthostatic hypotension is a cause of syncope, deconditioning caused by prolonged bed rest. So symptoms developing within several minutes of assuming upright position, drop in blood pressure with standing during examination, and is the findings. And the diagnostic approach is a clinical evaluation, sometimes tilt table testing. Anemia as a cause of syncope. Suggestive findings: chronic fatigue, sometimes dark stools, very specific, heavy menses, and diagnostic approach of complete blood count. Endocrine disorders, for example, adrenal insufficiency, hypothyroidism. Suggestive findings: symptoms developing within several minutes of assuming upright position, often associated symptoms of underlying disorder. Diagnostic approach is a basic metabolic panel, morning cortisol measurement. Cardio-cerebrovascular causes, basilar artery transient ischemic attack or stroke. Suggestive findings, sometimes cranial nerve deficits and ataxia. Diagnostic approach is computer tomography or MRI. Migraine, migraine is a cause of syncope. So migraine is aura with visual symptoms, photophobia, unilateral. And diagnostic approach is clinical evaluation. Other causes of syncope, prolonged standing, apparent by history, no other symptoms as suggestive findings. Diagnostic approach is a clinical evaluation. Pregnancy, a healthy woman of childbearing age, no other symptoms, usually an early or unrecognized pregnancy as a suggestive findings. Diagnostic approach, so urine pregnancy test. Hyperventilation, suggestive findings, often tingling around mouth, or on fingers prior to syncope, usually in context of an emotional situation. Hyperventilation. So diagnostic approach is a clinical evaluation. Hypoglycemia, altered mental status until treated, onset, seldom abrupt sweating, piloerection, usually history of diabetes or insulinoma. Diagnostic approach is fingerstick glucose, response to glucose infusion. So fingerstick glucose and response to glucose infusion. Psychiatric disorders as a cause of syncope, not true syncope. Patient may be partially or inconsistently responsive during events. So normal examination is a suggestive findings and often history of psychiatric disorders. Diagnostic is a clinical evaluation. But let's talk about drug causes. Bradyarrhythmia, for example, amiodarone, other rate-limiting drugs, beta blockers, calcium channel blockers, not zidroipiridine, and digoxin. Tachyarrhythmia, any drug that prolongs repolarization, for example, antiarrhythmics, some antipsychotics, some antidepressants, some antihistamines, and some fluoroquinolone, for an up-to-date list of drugs that can cause tachyarrhythmias. Orthostatic hypertension, so the drugs that causes. Most antihypertensive, rarely with beta blockers, very rarely. Antipsychotics, mainly phenothiazine, doroxubicin, levodopa. Loop diuretics, yes. Nitrates with or without phosphodiesterase inhibitor for erectile dysfunction. Quinidine and tricyclic antidepressants, vincristine. This concerning drugs. So evaluation should be done as soon as possible after the event. The more remote the syncopal event, the more difficult the diagnosis. The information from witness is quite helpful and best obtained as soon as possible. History of present illness should ascertain events leading up to the syncope, including the patient's activity, for example, exercising, arguing, in a potentially emotional situation, position, for example, lying or standing, and if standing, for how long. Important associated symptoms immediately before or after the event include whether there was a sense of impending loss of consciousness, nausea, sweating, blurred or tunnel vision, tingling of lips or fingertips, chest pain, all palpitations, lungs, palpitations, yes. About palpitations we have talked. Length of time recovering should also be ascertained. Witness, if any, should be sought and asked to describe events, particularly the presence and duration of any seizure activity. Review of symptoms. should ask about any areas of pain or injury, episodes of dizziness or renal syncope upon arising, and episodes of palpitations or chest pain with exertion. Patients should be asked about symptoms, suggesting possible causes, including bloody or teary stools, heavy menses, anemia, vomiting, diarrhea or excess urination, dehydration or electrolyte abnormalities, and risk factors for pulmonary embolism, recent surgery or immobilization, known cancer, previous clots of or hypocoagulate state. Past medical history should ask about previous syncopal events, known cardiovascular disease, and known seizure disorders. Drugs used should be identified, particularly antihypertensive, diuretics, vasodilatators, and antiarrhythmics. Family history should note presence of a young age of heart disease or sudden death in any family member. About physical examinations, vital signs are essential. Heart rate and blood pressure are measured with the patient's supine, and after 3 minutes of standing, pulse is palpated for irregularity. General examination notes patient's mental status, including any confusion or hesitancy suggesting a postictal state, and any signs of injury, for example, bruising, swelling, tenderness, tongue bite. The heart is auscultated for murmurs. If present any change in the murmur with Valsalva maneuver, standing or squatting is noted. Cerebral evaluation of the jugular venous waves while palpitating the carotid or auscultating the heart may allow diagnosis of an arrhythmia if an ECG is not available or uncertain. Some clinicians carefully apply unilateral carotid sinus pressuring during ECG monitoring with the patient supine to detect bradycardia or heart block, suggesting carotid sinus hypersensitivity. Carotid sinus pressure should not be applied if a carotid bruit is present. Abdomen is palpated for tenderness, and a rectal examination is done to check for gross or acute blood. A full neurologic examination is done to identify any focal abnormalities which suggest a central nervous cause, for example, seizure disorder. Red flags. Certain findings suggest a more serious etiology. Syncope during exertion, multiple recurrences within a short time, heart murmur or other findings suggesting structural heart disease, for example, chest pain, older age, significant injury during syncope, family history of sudden unexpected death, exertional syncope, or unexplained recurrent syncope or seizures. About the causes, although the cause is often benign, and it's important to identify the occasional life-threatening cause, for example, tachyarrhythmias, heart block, because sudden death is a risk. Clinical findings help suggest a cause in 40 to 50% of causes. A few generalizations are useful. Benign causes often lead to a syncope. Syncope precipitated by unpleasant physical or emotional stimuli, for example, pain, fright, usually occurring in the upright position. And often preceded by vagally mediated warning symptoms, for example, nausea, weakness, yawning, apprehension, blurred vision, diaphoresis, suggest vasovagal syncope. Syncope that occurs most often when assuming an upright position, particularly in elder patients after prolonged bed rest or in patients taking drugs in certain classes, suggesting orthostatic syncope. Syncope that occurs, we talk about benign causes. A syncope that occurs after standing for long periods without moving is usually due to venous pooling. Loss of consciousness that is abrupt in onset is associated with muscular jerking. Muscular jerking, yes. Convulsions. convulsions that last more than a few seconds, incontinence, drooling, or tongue beating, and it's followed by postictal confusion or somnolence suggests a seizure. Dangerous causes are suggested by red flag findings. Dangerous. Syncope with exertion suggests cardiac outflow obstruction or exercise-induced arrhythmia. Such patients sometimes also have chest pain, palpitations, or both. Cardiac findings may help identify a cause. A harsh, late picking, a basal murmur radiating to the carotid arteries suggests aortic stenosis. A systolic murmur that increases with the Valsalva maneuver and disappears with squatting suggests hypertrophic cardiomyopathy. Syncope that begins and ends suddenly and spontaneously is typical of cardiac causes, most commonly an arrhythmia. Dangerous causes: syncope while lying down, also suggesting an arrhythmia because vasovagal and orthostatic mechanisms do not cause syncope in the recumbent position. Syncope accompanied by injury during the episode increases the likelihood of a cardiac cause or seizure, and therefore the event is of a greater concern. The warning signs and slower loss of consciousness that accompany benign vasovagal syncope somewhat reduce the likelihood of injury. So testing typically is done: electrocardiogram, pulse oximetry, sometimes echocardiography, sometimes tilt table testing, blood tests only if critically indicated. Central nervous system imaging rarely indicated. In general, if syncope results in an injury or is a recurrent, particularly within a brief period, more intensive evaluation is warranted. Cardiac and brain imaging are not done unless indicated by the clinical findings, suspected cardiac etiology, or neurologic defects. Patients with suspected arrhythmia, myocarditis, or ischemia should be evaluated as inpatients. Others may be evaluated as outpatients. So, ECG, electrocardiogram, is done for all patients. The ECG may reveal arrhythmia and conduction abnormality, ventricular hypertrophy, pre-excitation, QT prolongation, pacemaker, malfunction, myocardial ischemia, or myocardial infarction. It's concerning ECG. If there are no clinical clues, measuring cardiac markers and obtaining serial ECGs to rule out myocardial infarction in older patients, plus ECG monitoring for at least 24 hours are prudent. Any detected arrhythmia must be associated with altered consciousness in order to be implicated as the cause, but most patients do not experience syncope during monitoring. So on the other hand, the presence of symptoms in the absence of rhythm disturbances helps rule out a cardiac cause, of course. An event recorder may be useful if warning symptoms precede syncope. Signal-leveraged ECG may identify predisposition to ventricular arrhythmias in patients with ischemic heart disease or in post-myocardial infarction patients. If syncopal episodes are inadequate, for example, less than 1 per month, or implantable loop recorder, so implantable loop recorder can be used for longer-term recording. So actually, it's up to you. Pulse oximetry should be done during or immediately after an episode to identify hypoxemia, which may indicate pulmonary embolism. If hypoxemia is present, computer tomography or a large scan is indicated to rule out pulmonary embolism, so the DMR is also done. Laboratory tests. So laboratory tests are done based on clinical suspicion, reflexively obtained laboratory panels are of little use. However, anyway, all females or of childbearing age should have a pregnancy test. Hematocrit is measured of anemia if anemia is suspected. Electrolytes are measured only if an abnormality is clinically suspected, not in all cases. For example, by symptoms or drug use, so it's clinically suspected, we measure electrolytes. Serum troponin is measured if acute myocardial infarction is suspected. Echocardiography is indicated for patients with clinically unexplained syncope, exercise-induced syncope, cardiac murmurs, or suspected intracardiac tumors, for example, those with positional syncope. Tilt table testing may be done if history and physical examinations indicate vasodepressor or other reflex-induced syncope. It's also used to evaluate exercise-induced syncope if echocardiography or exercise stress testing is negative. Stress testing, exercise or pharmacological, treadmill, value ergometry, pharmacological, why not, is done when intermittent myocardial ischemia is suspected. It's often done for patients with exercise-induced symptoms. Invasive electrophysiological testing is considered if non-invasive testing doesn't identify arrhythmia in patients with any of the following: unexplained recurrent syncope, unexplained red flag findings, ischemic cardiomyopathy, and unexplained syncope. A negative response defines a low-risk subgroup with a high rate of remission of syncope. The use of electrophysiologic testing is controversial in other patients. Exercise testing is less valuable unless physical activity precipitated syncope. So-called. Okay. Electroencephalogram is warranted if a seizure disorder is suspected. Epilepsy. Computer tomography and MRI of the head and brain are indicated only if signs and symptoms suggest of focal CNS, central nervous system disorder. So, in witnessed syncope, pulses are checked immediately. If the patient is pulseless, CPR is begun. Cardiopulmonary resuscitation. If pulses are present, severe bradycardia is treated with atropine, or external transthoracic pacing. Isopraterenol can be used to maintain adequate heart rate while a temporary pacemaker is placed. Tachyarrhythmias are treated. Direct current synchronized shock is quicker and safer for unstable patients, if tachyarrhythmia is present, of course. Inadequate venous return is treated by keeping the patient supine, raising the legs, and giving intravenous normal saline. Tamponade is relieved by pericardiocentesis. Tension pneumothorax requires insertion of a pleural cannula and drainage. Anaphylaxis is treated with paranetral epinephrine. Placing the patient in a horizontal position with legs elevated typically ends the syncope episode if life-threatening disorders are ruled out. If the patient sits upright too rapidly, a syncope may recur. Propping the patient upright or transporting the patient in an upright position may prolong cerebral hypoperfusion and prevent recovery. If in upright position. Specific treatment depends on the cause and its pathophysiology. During the use of machinery should be prohibited until the cause is determined and treated. So driving and use of machinery, cars, should be prohibited until the cause is determined and treated. Geriatric essentials. The most cause of syncope in older adults is postural hypertension, due to a combination of factors. Factors include rigid, non-compliant arteries, reduced skeletal muscle pumping or venous return due to physical inactivity, and degeneration of the sinusoidal node and conduction system due to progressive structural heart disease. In older adults, syncope often has more than one cause. For example, the combination of taking several heart and blood pressure drugs and standing in a hot place during a long or emotional service may lead to syncope, even though no single factor might cause syncope. And finally, key points of syncope. Syncope results from global central nervous system dysfunction, usually resulting from insufficient cerebral blood flow. Most syncope results from benign causes. Some less common causes involve cardiac arrhythmia or outflow obstruction and are serious or potentially fatal. Vasovagal syncope usually has an apparent trigger warning symptoms and a few minutes or longer of post-recovery symptoms. Syncope due to cardiac arrhythmias typically occurs abruptly and with quick recovery. Seizures have prolonged, for example, hours recovery period. If benign etiology is not clear, driving and use of machinery should be prohibited until the cause is determined and treated. The next manifestation of unrecognized cardiac cause may be fatal. So, goodbye. Don't forget to follow and subscribe our healthcare and education channel. Okay, and if it's possible, support our channel with your donates. So, in description of our video, you can see our MasterCard data. Thanks in advance, and see you in another lectures. Goodbye.